Welcome, all of you, to the first MMI webinar. I'm very pleased to be giving the first webinar and associated with MMI. What I want to do this evening is sort of a flyover of some of the new revolutionary concepts in managing coronary heart disease and cardiovascular disease, with the realization that we only have about 30 to 45 minutes. This will give you a flavor for what we're going to try to do in the seminars coming up in 2014 and 2015. So I'd invite you to look at what's coming up on the MMI website coming up at Harvard Medical School in September on healthy aging, where we'll present a lot of this information, but also coming up in October in Miami, which is a 3-day seminar. And one day will be just on cardiovascular disease. So hopefully all of you have been able to access the slides. So let's go ahead and start with some of these broad concepts in CVD and CHD. One of the things that's very clear now when you look at the literature, you look at people that come into the hospital with myocardial infarction, is that about 60 to 70% of them have what we would consider the top 5 risk factors under optimal control by the present recommendations of all the different societies. LDL's controlled, blood pressure's controlled, blood sugar's controlled, etc. So if that's the case, why is it they're still having heart attacks and coronary heart disease? And the reason is twofold. One, we're not defining the top 5 risk factors correctly. Most physicians are not doing the advanced lipid testing, looking at particle number and particle size. Most physicians are not looking at 24-hour blood pressure monitoring and determining whether or not the patient's still at risk for cardiovascular events or whether they even have good control of their blood pressure with either their medications or their supplements. And we also misdefine what is really dysglycemia. So we've got to redefine the top 5 correctly. But in addition, we're missing the evaluation and treatment of some 395 other risk factors that are well published and well described. So based on that concept, we've got to reorganize the entire approach to cardiovascular disease by looking at the risk factors more appropriately and start to measure those risk factors related to the 3 top reasons that people have cardiovascular disease. So the blood vessel has only 3 basic responses to an infinite number of insults: inflammation, oxidative stress, and immune dysfunction. So no matter what the insult is, whether it's one of the top 5 risk factors or it's homocysteine or heavy metals or infections or something else, the blood vessel can't respond in any other way other than those 3 things listed on your slide, which allows one to begin to address vascular disease in a much more pathophysiologic way, looking at those end results, doing appropriate tests to define what's causing them, then asking the very important question, why is the blood vessel inflamed, or why do you have oxidative stress? What set off the immune attack on the vascular system? Remove the insult and then treat those finite risk factors as best you can until you remove the insult. So the body is a very smart organ, as is the blood vessel, and it never does anything to really try to destroy itself on purpose. What happens then when an insult comes into the artery is the blood vessel responds correctly and it's responding normally. And if that's in an acute setting, then usually it takes care of the insult, it ends the problem, and all goes well. However, if you continue to have chronic insults to the arterial system, those correct and normal responses now become dysregulated. And so over time, that makes the blood vessel become injured as really sort of an innocent bystander with the body's attempt to control whatever that insult might be. And all this goes on, so there's insults, there's vascular risk factors, but as you know in practice, the risk factors do not always correlate with the presence of vascular disease, and vice versa. I mean, you've seen lots of patients who smoke, they have bad diets, they're overweight, they have bad risk factors, and yet they don't tend to have any vascular problems. And on the other hand, you have this 25 or 30-year-old patient who does everything correct, and they have coronary heart disease at a very early age. So there's a lot of things we're missing. You know, it's genetics, it's epigenetics, it's how genes are translated, gene expression patterns, and then, of course, all the different risk factors. So we've got to learn not just to measure the risk factors, but also to measure exactly what it is that's going on with, you know, the risk to the blood vessel. So, you know, if you look at the different types of tests that are available to vascular disease, there's a lot of non-invasive tests that we can do, like the EndoPat, which measures endothelial function, and carotid IMT, coronary calcium scores, and other things will help you detect early and aggressively treat coronary heart disease. So on this slide, you've got a cross-section view of an arterial wall. And you see the lining, which is the endothelium, and right below that's the muscle, and then outside that's the connective tissue. Most of the action is going on right there in the endothelium, which determines what goes on in the blood, but also what goes on in the vascular smooth muscle. So if that endothelium is functioning normally, everything goes well. But if it doesn't function normally, then you're going to start getting vascular injury. Now, normally, the body can repair the endothelium with what are called endothelial progenitor cells, which come from the bone marrow. And those will replace dysfunctional endothelial cells and reestablish normal stasis, which is related to nitric oxide production, but also reducing inflammation and oxidative stress. So the endothelium is really what's causing the downstream finite responses, but it also is protected. So nitric oxide is one of the anti-atherosclerotic, anti-hypertensive mediators that protects the arterial wall. But if nitric oxide is decreased or the bioavailability is down, then this is what happens. You get oxidative stress in the arteries and the kidney. Inflammation is measured by C-reactive protein in both the kidneys and the arterial system, and immune dysfunction with T cells and B cells that literally attack the arterial vessel and cause an autoimmune reaction to the arteries. That then leads to more endothelial dysfunction and vascular smooth muscle dysfunction, and all this is superimposed on your genetics and genomics. This is one of the new concepts related to the insult theory of the blood vessel. And you really can divide this into two major groups. The biomechanical side, which is blood pressure and hemodynamics, and on the other half is the biochemical, which would be you know, microbes, nutritional problems, metabolic changes, and sterile antigens. Now, all of these things can directly attack the blood vessel through different receptors. And there's at least 4 receptors that you need to be aware of. One is the toll-like receptor, or TLR. The second is the nod receptor, and those are both under the same group of receptors called pattern recognition receptors, or PRRs. Now, the PRRs, if they're stimulated, create these finite responses, which are inflammatory, oxidative stress, and immune dysfunction. There's another receptor called the calveoli, and in the calveoli are lipid microdomains. That's where cholesterol is formed. You have cholesterol crystals, and also that's where nitric oxide is importantly placed. And if the nitric oxide is displaced from the calveoli, then you end up with a decreased nitric oxide bioavailability. So if you can stop the insults at the beginning of all this, then you can reduce some of the downstream effects and reduce the vascular damage. And we have a lot of different nutrients, particularly, and supplements that can block those receptors and therefore reduce some of the vascular disease. One of the best ones that blocks the toll receptor and the pattern receptors is curcumin. So all these insults come in, microbes, sterile antigens, nutrients, whatever. That leads into inflammation. Establishing the PRRs causes immune disruption and oxidative stress. And all the inflammation then can go down and cause insulin resistance, particularly related to adipose tissue and release of cytokines and chemokines. So here's a list of some of the things we know about that can actually inhibit those pattern recognition receptors, blocking either the TLR receptor or the NOD receptors. This is a very, very important list. A lot of these things are supplements, a lot of them in your diet. You've got curcumin, cinnamon, sulforaphane compounds, which would be like in broccoli, resveratrol, green tea extract or EGCG, luteolin, which is found in a lot of different vegetables like celery, pepper, rosemary, carrots, oregano, and others. Quercetin, both a supplement but also in tea, apples, onions, and others. And then chrysin, which is a TLR1 blocker. So the body responds in two major ways. You've got the biomechanical and the biohumoral responses. And if we can learn to modulate those receptor interactions to the external insults and the internal insults, then by hitting the concept in a higher relationship, you can block some of the downstream effects. So the endothelial lining, which is shown here, just like the enterocyte, can have gap junctions. And when you have a large gap, things can easily slip through there. So the leaky gut syndrome is very similar to the leaky endothelial syndrome. And you've got then lipid particles and debris and microbes and other things that can get into the subendothelial layer and set off those finite responses in cardiovascular disease. We also know that most of our genetics now don't even relate to the top 5 risk factors if they're cardiovascular genomics. In fact, most of the cardiovascular genes are inflammatory in nature. And there's different ones we can look at. There's the 9p21, different SNPs. But all of these, if you look at the different loci on those genes, seem to mediate the primary cardiovascular events through inflammatory processes, which then tie in directly with oxidative stress and immune dysfunction. So atherosclerosis is really first defined with endothelial dysfunction, and that leads to vascular disease. And after you eat, a lot of the things that are insults occur. So inflammatory foods, high blood sugar, high triglycerides, and then the bacteria, either live or dead, and the bacterial products that come across really create a metabolic endotoxemia. So every time you eat, you're creating metabolic endotoxemia, endothelial dysfunction, and actually increasing the risk for atherosclerosis. And that the ability of the body to respond to those meals is really directly related to what you eat. So more glucose, more fats, particularly saturated fats and trans fats, can set off a very bad inflammatory reaction with metabolic problems. The body remembers that, and the next time it's exposed to something, it'll actually have a heightened response that's more severe than it was before. And then if you add something like sodium chloride to your carbohydrates and your fats, it gets even worse. So there's more endotoxemia, more bacterial products, more leaky endothelium, and more inflammatory and oxidative stress response. Now, part of that you can block by using good foods, for example, low glycemic foods, monounsaturated fats, polyphenols, antioxidants, phytochemicals. But the idea is to try to remove all the micronutrient inflammatory insults and replace them with a more appropriate diet that does not cause metabolic endotoxemia. This disease starts actually in utero, so by the time you're just a few years old, you've already started to develop endothelial dysfunction, and we've got autopsy studies that show now in your teen years there's already coronary heart disease, abdominal fatty streaks in the aorta, and this progresses even faster, particularly now where we have an obese population, a lot of diabetics. So vascular disease is actually getting not only worse, but occurring at a younger age. So the concept we started out with, which is most of your patients who end up in the hospital with a myocardial infarction have theoretically good control of their risk factors, but in fact they probably don't because we're not measuring all of them correctly or we're not measuring at all. So if you look at people who have coronary heart disease, the way it actually develops is extraluminal initially, and then later on becomes a luminal disease. So you see on the far left the patient who has really normal endothelium and a normal lumen. So the gray represents endothelial lining, and then inside that's the lumen. And then you go to the middle section, you have a patient who, has got moderate coronary heart disease with increased thickness of the endothelial lining, but notice the lumen's really the same size. So if you did an arteriogram on that patient, it would be normal. But if you did an electron beam tomography or a CT angio, you would see all this plaque in the subendothelial layer, and you would know this patient does in fact have coronary heart disease. But later on, as the subendothelial plaque gets bigger, it then starts to actually erode into the lumen. And now you have severe CHD with obstructive disease, and that's where you'll start to actually see it on a coronary arteriogram. So you've got to pick up the disease earlier with different types of tests and then get it treated aggressively. What's important to note that is most patients, in fact about 68% of those who have a myocardial infarction have less than a 50% stenosis in a major coronary artery. If you do intravascular ultrasound by placing a probe inside the coronary arteries, you can see that this disease, again, starts at a very early age. And in this particular study, this was done 14 years ago, by the age 39 in the United States, 60% of people had coronary heart disease as defined by intravascular ultrasound. And this shows you how that looks with an arteriogram. On the left-hand side, you'll see a patient who had a coronary arteriogram, and it's totally normal, wide open patent arteries. If you see the arrow up in the left-hand corner of your slide, let's do a cross-section of that artery with an intravascular ultrasound, which is now on the right-hand side. And what you see, all that white stuff in there, is subendothelial plaque, and that's the beginning of the atherosclerosis, but it's not showing up on the coronary arteriogram. So this person will get a free pass and say you've got clean arteries, but when you know the pathogenesis of the disease, you know that that's not correct. This patient has significant coronary heart disease as defined by IVUS or by CT angio. And of course, this is what we're trying to prevent, which is plaque formation. This is really a nasty plaque with a very intense lipid core, a lot of macrophages, the smooth muscle cell is very activated. And then aligning the core is a fibrous plaque that's very thin, which allows for the lipid core to easily erode through that area and then rupture into the lumen. And when it does that, it's what causes acute coronary thrombosis. So one of the things we'll be talking about at the upcoming MMI symposia is how to regress the plaque, stabilize the plaque, make it more of a less rupture-prone plaque, and then also even prevent the formation to begin with. And we can do that with both nutrients, diet, and also drugs. And this is what happens. There's two scenarios here. Here you have your early plaque on the left, and then if you go up to the top, you have this very thick cap, which creates more of a stable plaque because all that lipid core doesn't tend to rupture as easily. But below that, you see the more aggressive, active lipid core and a very thin fibrous cap, and this is the one that tends to rupture, where it then spews out all that lipid core into the lumen and causes acute thrombosis. So that's your first myocardial infarction. So we've talked about the fact that there's the top 5 risk factors, and then there's another 395 risk factors on top of that aren't being measured. And this is a slide that really takes what I would consider the top 25 modifiable risk factors. And this is one of the things we're going to talk about in detail, both at Harvard but also in Miami at the MMI Symposium, and talk about how these should be measured, how they should be treated, and so forth. But you can see this is a nice start to changing the way you approach coronary heart disease by at least taking at least 25 risk factors now and looking at them in a very different way, measuring them and trying to treat them or remove the insult when they occur. And then we'll talk about all the different tests that you can do to actually improve early diagnosis and then follow your treatment. So we have functional tests like Endopat, the computerized pulse wave analysis, which measures the arterial elasticity, a digital thermogram for endothelial function, heart rate variability, obviously EKG treadmill, but a new type of cardiograph, which is called magnetocardiography, which is very highly sensitive and specific for coronary heart disease at about an 80 to 90% ratio. Then we have structural tests like carotid IMT, electron beam tomography, CTA, calcium scoring, which can be cardiac MRIs, and of course echoes and ABIs. And then we got the fancy stuff for the more advanced patient with ultrasounds and nuclear imaging, and of course the angiogram. And so the carotid artery structure, for example, is sort of a middle functional structural test that correlates very highly with coronary heart disease. And so if you've got plaque in a coronary artery or plaque in a carotid artery, there's about a 50% chance you'll have it in the opposite system. And this is a very simple test to do. It takes about 30 to 45 minutes. You can measure both plaque as well as intimal medial thickness. And you can see in this slide, patient who has a little bit of plaque, and also the intima is very thick, so this patient will have very early carotid artery disease. And we also do 2D echoes to look at ventricular function and is the muscle stiff and are the valves working. This gives you a very good idea whether or not the patient has hypertension or some other risk factor causing cardiac disease. And of course you have electron beam tomography and the coronary CTA and calcium scoring, which give you a very high correlation between calcium in the coronary arteries and future cardiovascular events. And we have subtraction CT angio, which can give you very nice views of what the coronary arteries look like non-invasively. And we routinely now do EndoPAT, which is the measure of endothelial function. And this is an example of that test. It's very easy to get a pulse wave, and it gives you your central blood pressure, and then it measures the capacity of the artery to dilate, C1 and C2 compliance. So this is called a CV profiler. And then we have the EndoPAT, which measures also endothelial function. That's the ability of the artery actually to dilate. And the dilatation, after you occlude the artery over a period for about 5 minutes, creates a ratio between the right arm and the left arm. And what you're seeing on the left-hand side is in the arm that was occluded, a very large black wave. And that means that there's a lot of nitric oxide in the artery, which causes it to dilate, so that's a healthy artery. But if you look on the other side, you'll see a patient who has very poor endothelial function, and there's a very small increase in the post-ischemic wave, so they have very low nitric oxide. And this test has a very high correlation with future myocardial infarction and coronary heart disease. This test only takes about 15 or 20 minutes to do in your office. It also has a very high correlation with future events based on the Mayo Clinic trial, so that the lower the EndoPAT put together with risk factors, the greater the risk for patient having coronary heart disease or myocardial infarction in the future. And then we have a lot of advanced lab testing that we'll talk about that help you define whether patients at risk for cardiovascular disease, where they have one of the finite risk factors, looking at either lipid profiling, advanced testing, renin activity, 24-hour blood pressure monitoring, and then different types of biomarkers for renal function and the risk of thrombosis, micronutrients, toxicology screening, and of course genetic testing and genetic expression testing. So we're going to put together basically a very impressive integrated cardiovascular program that looks at proper nutrition, caloric restriction, proper type of exercise with the ABCT exercise program, how to reduce inflammation with dietary means, proper sleep habits, stress reduction. And all these things, if done correctly, can result in up to a 70% reduction in future cardiovascular events in myocardial infarction. And then we'll have a specific discussion about nutritional supplements, antioxidants, immune modulators, and how you combine your natural component therapies with selected drugs like ACE inhibitors, ARBs, calcium blockers, metformin, and what's the role of aspirin and other thrombotic agents and bioidentical hormone replacement. So there's a lot of potential now to reduce cardiovascular disease, if you recognize the new technology, you recognize the new downstream effects and the pathophysiology that expands you from your old risk factor analysis, which is very narrow, to a new risk factor analysis with better definition of the top 5 risk factors, but also a better review of the other 395 risk factors. So in essence, we've got to redefine the risk factors, close this gap, look at the other 395 that are out there, and try to come up with a way to improve our membrane physiology by blocking those receptors that cause inflammation. And look at this more in a systems biology approach as opposed to just this static model that we've used in the past. And realize that there's a lot of disease out there, a lot of risk factors, but there's this gap between a risk factor and the translating into vascular pathophysiology. And that's what some of these tests we've talked about will allow you to do. And then you go back and look at the biomechanical and humoral categories, those top 25 risk factors, and ask the question, what caused the patient to be inflamed? Try to find the insult, remove it, look at their genetics very well, try to clean up their diet so they don't get the metabolic endotoxemia, and do appropriate tests to find out, whether the disease is either extraluminal or it's actually now encroaching on the lumen and causing intraluminal disease. So I'm gonna stop there. I know we've covered a lot of information. As I said, this is an overview for our future MMI symposiums. So if you have some questions, go ahead and put those on your board there, and they'll pop up on the screen here, and Jordan can repeat them, and we'll try to answer them for you. And I thank you for joining us tonight, and look forward to seeing you all at one of the upcoming symposia.
Thank you so much, Dr. Houston. I do have a question. Dr. Houston, we saw the schedule for MMI Miami, and we see you are lecturing the cardio lecture day. What topics will you be covering for live course number 3 in Miami?
I'll be covering new concepts in hypertension, dyslipidemia. Then we'll do a lecture called Functional and Metabolic Medicine Interrelationships, where we tie in cardiovascular with gastrointestinal and neurological issues and try to put it together in a nice holistic pattern. And the last part will be a more detailed review of what we did tonight, looking at coronary heart disease and CHD risk factors.
That's great. I do have another question. Can you speak on any specific marker that is predictive of CAD?
Probably the best single marker that we have available is an advanced lipid test that measures the LDL particle number. And if you do that along with a C-reactive protein, which measures inflammation in the vasculature, those two have the highest correlation with obstructive coronary heart disease as well as subintimal disease. So LDL particle number and C-reactive protein.
Great. I have one more question. Given the current atmosphere of healthcare reimbursements, are there any obstacles to consider in ordering the advanced testing you are discussing this evening?
The advanced lipid test is, and actually some of the others we briefly discussed, is now covered by virtually all the insurances, and they're very inexpensive. In fact, an advanced lipid profile now is not much different than one of the older lipid profiles that has been done in the past. Most of them fall in less than $100 and they're paid by insurance.
Okay, thank you. What are your thoughts about myoperoxidase and plaque tests? Is it useful for screening?
Yes, both of those are helpful. The myeloperoxidase, or MPO, is an oxidative stress marker that's produced by the white cell in response usually to a bacterial infection or some other insult. And the MPO actually attacks the HDL cholesterol and makes it dysfunctional and increases one's risk for coronary heart disease. So an MPO is a great indirect marker for dysfunctional HDL, which is going to result in a abnormality in reverse cholesterol transport and removal of cholesterol from tissue, which increases your risk for atherosclerosis and CHD. The Plaque 2 test is also very important. That's released from damaged cell membranes, and it's a very good marker for future stroke, TIA, and myocardial infarction and plaque burden. So I measure both of those routinely, and I can predict very accurately with those plus other tests we do patients' risk for having an MI or CHD.
Great. How effective is berberine on lowering LDL-P?
Berberine is very effective in virtually all the lipid particle reduction, LDL reduction, and also can even improve the LDL size. Berberine has a lot of mechanisms of action related to glucose and to lipids. One of the major effects, though, is it improves the receptor in the liver for LDL excretion. And there's a very important enzyme that's made in the liver called PCSK9. And PCSK9 is actually increased in the presence of statin drugs and maybe radius rice, which makes the statins over time less effective in getting rid of LDL because it blocks that receptor in the liver. If you give berberine with a statin or berberine with radius rice, you decrease the PCSK9 and actually make the LDL receptor in the liver more avid for LDL circulating in the bloodstream, so it's excreted better by the liver. You can actually decrease LDL levels by another 25% or so by using berberine in conjunction with statin or radius rice. You don't need much. Actually, 500 milligrams of berberine a day can often give you those dramatic effects.
Great. I have another question for you. Thank you, everyone, for your great questions. What is your opinion regarding impedance testing for HRV and other cardiovascular risk factors?
HRV is heart rate variability, and there's a lot of great tests that are available for measuring HRV, and we do it routinely in the Hypertension Institute. HRV is a nice way of measuring your autonomic function, your parasympathetic and sympathetic balance. So if you have abnormalities in HRV, then you're at higher risk for not only arrhythmias, but also for coronary heart disease and myocardial function disorders.
Great. Is taking nitric oxide supplement, pharmaceutical grade, helpful as a maintenance for heart disease?
You can't really take nitric oxide itself. You have to take something that's a precursor for nitric oxide, which is nitrates, or you try to form it by giving the precursors like arginine. The two major methodologies of making nitric oxide in the body are nitrites and nitrates, which comes from dark green leafy vegetables and beets. And you can take that in a wafer form. It's called Neo-40. And Neo-40 was developed by Nathan Brown, University of Texas. And we've done studies with that, and it actually improves endothelial function, arterial elasticity, and lowers blood pressure, and it's very useful in vascular disease. You can also give arginine and citrulline as a precursor to nitric oxide, but that one has to be used a little more carefully, and it's not as effective in patients over the age of 40. But that's the two ways that you make nitric oxide, which is a gas, which is why you can't really take nitric oxide in an oral form. You have to take something as a precursor.
Okay, what role do you see in advanced testing, such as high sensitivity troponins, in order to assess risk?
Troponin is going to help you if you have myocardial damage. So in a patient who's experiencing chest pain, unstable angina, or maybe you think they're having acute coronary syndrome or MI, troponin is very helpful to demonstrate that you're causing myocytes to die and release troponin into the system. But a lot of people can have significant coronary heart disease but not have elevated troponin because they haven't actually caused damage to the myocardial cells yet.
Okay, how do you lower homocysteine if high-dose B vitamins are not effective?
Well, if you look at the methylation pathway, there's a lot of other things other than B vitamins you have to put into the mix, like serine and betaine. But probably the most important thing is to be sure you're giving activated folic acid. So 5-methylfolate has to be given. But you should also, if you have a resistant patient, measure the MTHFR and see if they have one of the two SNPs. If they're heterozygote or homozygote for that particular genetic disorder, then you're going to have to give more methylated folate. Heterozygote patients may only require, 5,000 to 10,000 micrograms a day, but for homozygote, for both SNPs, they require even higher doses than that. Combination of B vitamins, serine, betaine, and other things to help reduce homocysteine and improve methylation.
Okay. If someone tests positive to have a genetic heart issue, can it be controlled with diet, supplements, and exercise?
Yeah, because, the genetic disposition for cardiovascular disease doesn't necessarily mean the gene's turned on. You can turn the gene off with appropriate environmental actions like diet and exercise, weight loss, proper sleep. For example, there's one gene called 9p21, and 9p21 is the best cardiovascular gene I think we have that we measure, and we do it routinely in the Institute. And if you have a homozygous SNP for 9p21, your risk for heart attack is anywhere from 50 to 70% higher than a normal patient. But that gene, the way it causes coronary heart disease is through inflammation primarily, and then oxidative stress and immune dysfunction follow. So if you do the right things, you can basically turn the gene off and then sort of downstream, which is inflammation, very low, and you can actually do incidents even though you genetically predisposed to it.
That's great. We'll have one final question. Are there any contraindications to the use of arginine?
Yes. And a patient who has acute myocardial infarction or acute coronary syndrome, you do not want to give arginine to those patients because it actually can increase oxidative stress through peroxynitrite, and there's a study in JAMA that actually showed increased risk of death and extension of their MI giving arginine in that setting. Great.
There are a lot of other questions. Dr. Houston, are you open to taking a few more, or shall?
Sure. Yeah, let's take a few more, and then hopefully those of you that are able to will be able to answer all of your questions either online, or if you have a chance, we'd love to have you come to one of the symposiums. But yeah, Nancy, go ahead and let's pick up a few more.
Okay, sure. What is the best way to shift small, dense LDL to a more buoyant form?
The two best mechanisms are niacin and omega-3 fatty acids. And I just literally 2 days ago, I had a patient that came in with exactly that pattern, a high LDL particle number and very small LDL. And they were literally off the scale on the lipoprotein analysis we did through SpectraCell. So I put him on a combination of reduced rice, niacin, and omega-3 fatty acids. I saw him back at 2 months. He just came in yesterday for his follow-up visit, and all of his numbers were back into the normal range on that combination. So I know it works. This is not the only patient, but this one that I've had this week. But almost everybody, if you give the right doses of those two things, will have a response in both their pattern, number, and size.
Great. Should very low homocysteine be treated?
It's a good question. There's a lot of people that have either hypermethylation or hypomethylation, and we don't really know that much about the hypomethylation issue. So I don't know that anyone can answer the question that if a low homocysteine is out there, should you treat it? I would say at this point, until we have more data, you just leave it alone, and hopefully that's going to be a low risk factor for them.
Does any lab do advanced testing? Are there specific lab resources you would recommend?
Well, for advanced lipid testing, there's several labs, and then for advanced cardiovascular testing, there's labs. So let me just mention the lipid testing first. The ones that are, I think, best validated are lipoprotein analysis through SpectraCell. Then there's Berkeley Heart Lab, which was just bought by Quest. Then there's NMR, which is LipoScience. There's Cleveland Heart Lab, Boston Heart Lab, and then HDL Labs, and Atherotech. Those are your top advanced lipid testing. For advanced overall cardiovascular testing, I tend to use Boston Heart and Cleveland Heart as the top two for my office.
That's great. I think this is a nice way to end the webinar. MMI would like to thank everyone for their time, especially Dr. Houston. For all the participants tonight, we would like to present you with a very special offer that will only be available for 48 hours. If you are interested in the live courses in Miami, please call and mention that you are a listener tonight. We hope that you enjoy the webinar. If you have any questions about the program, questions for Dr. Houston, or if you are interested in registering for this event in Miami, please call 561-910-4960, extension 7905. You can call now and I will secure your spot. You can also email Lindsay, Lindsay, at mmimedicine.com. Thank you again for your time and have a great evening.